Hi everyone. This week we have our presenters are Dr. Katherine Blondon and Dr. Frederic Baroz. And then, Dr. Katherine Blondon is an internist and clinical informatics at the University Hospitals of Geneva. Her research journey began with a focus on clinical reasoning and later expanded to improving communications through patient handoffs. Since 2013, she has been actively involved in teaching interprofessional collaboration at both undergraduate and postgraduate levels and has led a hospital-wide initiative on this topic over the past 4 years. Her interest in mobile health applications led her to the field of clinical informatics, where she now works within the medical directorate. She leads multiple projects, including the design and implementation of a clinical pathway tool, an alert system integrated into the EHR, and mobile applications to support clinician workflows and patient medication management. She also chairs the institutional committees for applied AI initiatives and mobile app development. Her current project is exploring how clinical documentation can enhance interprofessional collaboration, bridges her earlier research in clinical reasoning and communication with her ongoing work in informatics, aiming to drive innovations in care delivery through digital tools. And Dr. Frederic Baroz is a board-certified internist and has been practicing as an attending a physician since 2017. From an early age, he has been passionate about medical informatics, which led him to develop a deep interest in biostatistics and machine learning for healthcare. In 2022, he was awarded a scholarship from his hospital and relocated to Montreal to pursue a master's and PhD at McGill University focused on applying machine learning to healthcare research. His research interests include unsupervised clustering methods, synthetic data generation, and the use of large language models for clinical research and decision support. And now I'll give the floor to our amazing speakers for the talk of From Notes to Shared Understanding, Rethinking Clinical Documentation for Team-Based Care.
Thank you so much for this introduction and the invitation to come speak to you. So can we start with the next slide, Frederic? So today I wanted to talk to you about our more recent interests in improving interprofessional collaboration. And I mean, a lot of the current approaches have been around how to improve patient safety through teaching communication, structured communication, improving care coordination, leadership skills, how to provide mutual support, situation awareness, and thinking about how monitoring can help get a shared mental representation. But there's actually been very little work done on thinking about how all that time spent on clinical documentation could also help improve collaboration between health professionals. So our work today is mainly to think about how clinical documentation could actually be helpful to improve interprofessional collaboration. So the first step in this process was to understand how different types of professionals conduct their clinical documentation process. And then second, we were trying to think about how language models could help us create summaries, but then we were wondering what the language models representations of interprofessional actually was. And then we'll just go over outlines of the third and the fourth step, which will be implementing our proposed summaries into the EHR system and how to develop a learning model. And I'll go through that at the end briefly. So coming back to the first step, this was our first study on understanding how doctors and nurses actually conduct their clinical documentation process, because that's the first step in understanding whether it can be useful or not to improve. And so when we were thinking about how doctors and nurses write in different sections of the EHR, they actually write different things. They have different formats. Doctors think about problem lists. They write progress notes. Nurses think about nursing diagnoses and nursing targets, and they write observation notes. And other health professionals use other types of documentation. And if you think about patients as well, they might have their own portal. And so each one is accessing different sections of the EHR. And we're meant to use all of this together to take care of patients and manage everything with a shared mental model. That sounds a little tricky. If we go back to nursing, sorry, Frederic, go back to nursing. Nursing uses a type of terminology that's the NANDA International Nomenclature of terminology with diagnoses and targets, and they have a structure for each nursing target where there's a structured note with data or observation, followed by action and results. Doctors, on the other hand, thank you, Fred, don't usually follow strict terminology. There might be some structure, but that's not necessarily standard. And in our healthcare system, we have a problem-based documentation process with an institutional list of problems. And for each problem, of course, we're going to be detailing some description of the patient's context and symptoms and signs, some notes about the workup that we're doing and differential diagnoses if it's relevant, and then reporting back on the latest labs and imaging before we get to the treatment plan and the monitoring that we're going to conduct. And what's actually really interesting is because everyone writes in different areas of the electronic health record, not everyone actually takes the time. I mean, we already spend so much time in our own sections. Who is going to actually spend time reading another professional's section? And there's several articles that report on that. So understanding how we proceed in doing clinical documentation was part of the basis of this reasoning. So one of the things that we have to do is when we generate documentation, it's actually the result of observations and of clinical reasoning. And we use that information as when we read up on a patient's chart to give insight into the patient's prior, present, and future care. And that's what we were hoping could help us improve the collaboration within among health professionals. And so to be able to use the documentation in that way, we needed to get a better understanding of how people actually go around doing this documentation and clinical reasoning process, and finally thinking about what is relevant for one professional and what is relevant to another professional and what is actually being written in the EHR system. So what we did was we conducted 3 focus groups with doctors and nurses from internal medicine, geriatrics. And so we had these 3 focus groups, and we put doctors and nurses in teams of 1 doctor, 1 nurse, and we created 10 typical patient cases and identified 3 typical phases in the patient's management. The first was the admission phase, which was the first 1 or 2 days of the hospital stay. We initially had a section for the mid-hospital stay, but then realized maybe it wasn't as relevant and focused more on the admission and the discharge planning, which is for our patients in our hospital, it's on average an 8-day stay. So we considered the discharge planning between days 6 and 8, approximately. And so we put the doctors and nurses in teams. We gave them charts to go through with all kinds of information, as I mentioned, and we gave them cutouts of different clinical findings about labs and vital signs and administrative data and prescriptions. And we asked, and we also gave them the blue and the green notes, which were the nursing targets in green and the blue doctor's problems lists in blue. And we asked them individually to recreate what they would put in a patient's chart, and then to discuss together what was relevant amongst the things that they'd written down and to prioritize them as needed for the patient's care. And finally, they drew links between these different elements that they pasted onto this chart. And we conducted a descriptive analysis of this process and a qualitative analysis comparing and contrasting the different findings. So our 26 participants, we had 8 doctor-nurse teams from geriatrics, and we had 5 doctor-nurse teams from internal medicine. We had a majority of residents with 4 supervising physicians. We had many ward nurses and 2 nursing trainers who actually came twice to 2 focus groups. And we had a majority of female participants with 7 female nurses and 11 female doctors. And on average, during the 90 minutes that they were provided for these focus groups, teams discussed 1 to 2 patient cases overall. And so as we distributed the 10 patient cases, that allowed us to have some amount of overlap between these cases. So next slide. Here's an example of what was produced. And so you can see on the left-hand side the list of the problems that the doctor wrote down in the order of which he considered was important at admission. And on the right-hand side, way on the far right in green, are the nurses' notes in the order again that it would be written up with the priority from top to bottom. And in the middle, they pasted what they considered useful information, relevant findings from vital signs, labs, and other elements in the chart. And then finally, they drew these arrows to show the links between the different elements, between the doctor's problems, the nursing notes, and all the things in between. And there's another example following up here for the discharge process, and you can see this one's a little less organized, it's less dense. You can see that some of the problems probably have been resolved, and some of the nursing notes now have become focused on the discharge process and understanding what the patient's situation at home is. And in blue, they've added additional post-its and things that they would consider for discharge. So this shows us how people were thinking about what is a priority action, what are tasks that need to be conducted before being able to discharge the patient. Next. And so in our qualitative analysis, we saw that there was a wide variability between the different elements that were considered relevant across teams and across cases. For example, we looked overall in the 10 cases, there was one case with one doctor problem, and that was it, and another that had up to 18 different doctor problems that were documented as relevant. And for the same case, actually, there was the minimum and the maximum range were 3 versus 11 problems for a single case. And likewise, for nursing targets, we saw a range from 1 to 12 different targets that were used in the different cases. And again, comparing for within a single case amongst the different types of lab results, one team considered 5 labs relevant and the other considered that 12 labs were relevant. So again, a wide range of relevant information identified. And what was also interesting was you couldn't consider that you could limit the relevant information to abnormal findings. Of course, some of the normal findings were also considered relevant in these patient cases. So we were realizing that the process of documentation itself becomes quite subjective, and different users may have different approaches. And we saw that cultures in internal medicine and geriatrics were different even within our same institution, and that the tendency was for documentation in the internal medicine wards to integrate more elements about medications and prescriptions in the different notes and even for the nursing side. Whereas geriatrics were more focused on the patient's state and more on the clinical findings. And that was already a difference that we could see, even though nurses may change between one ward and one division and during the time that they're working. So that was one of the conclusions. And what was actually really interesting was teams appreciated learning together and thinking and learning from each other about how the documentation worked. Doctors tended to focus a lot more on the diagnoses and how to do the workup in the treatment plan, which is pretty expected from what we are describing initially. And nurses were more focused on the impact on the patient and on the psychosocial aspects for patient care. And sometimes associations were obvious for everyone. If a patient came in with heart failure and we were talking about difficulties with respiratory function, that association was pretty clear. They had difficulty breathing, they were short of breath. Whereas in other cases, the associations were more vague between the general problem and between what we put in the middle of those structures with the vitals, the labs, and the other elements, and the different nursing targets. So again, variability was a big issue. Another thing that was interesting was, whoops,
Sorry.
nurses had more of a tendency to be reading the doctor's notes, whereas some of the doctors had never even considered looking at nursing notes. And this was more obvious for the junior residents who it just didn't occur to them to read other parts of the chart. And what was interesting in the nursing notes for doctors was for example, the certain aspects preparing for discharge, because nurses documented more about how the patient lived at home and the daily activities and needs for additional support, and that was useful for discharge planning. And those are typically things that the doctors weren't so focused on in their documentation. Another thing that we found was the differences about timelines, and that goes to our next slide, where we can see that the blue, again, the doctor problems tend to last throughout a hospital stay. Like if a patient's hospitalized for pneumonia, chances are the problem's going to stay pretty much until the end of his stay. And the same for chronic diseases like diabetes. Whereas nurses have different targets that they begin at at the beginning of a shift, and at the end of the shift, they'll reassess and see whether they need to keep that target open or whether they can close it and say, well, that problem is dealt with. And here, for example, the patient only has fever for a day or two, and they might not have appetite for a day or two, but again, those are much shorter notion in terms of the timeline, and that's something that we considered important for our results. Next slide. And so we also saw that the reasoning processes between doctors and nurses were different, whereas doctors use the symptom to think about where it comes from, what is the origin of the symptom, so they orient more towards the workup and the diagnoses, and that leads them to what to do for the treatment plan. Whereas for nurses, a symptom was going to be more focused on what impact it would have for the patient, leading them to have different interventions that they would put into place as an action that they would later reassess later, often during the shift, to see whether the desired outcome was happening or not. And the discharge preparation was, as we mentioned before, a great place to see these differences between the reasoning process, but it was actually obvious throughout the whole of the hospital stay. What was also interesting was the associations that we saw in the beginning. For example, for a patient with pneumonia who has trouble breathing, who's coughing, who has fever, and those are all things that the nurses are going to be monitoring and writing up on, are associations that are going to change over time because as the symptoms get better, pneumonia might be associated with difficulty in mobilization when planning for discharge and oriented towards better physiotherapy and patient rehabilitation preparing for discharge again. So the associations between nursing problems and doctor problems actually change over time. So that was also interesting. And then finally, we saw that for the different stages that we looked at between admission and discharge, that there was a sort of central core of labs, vitals, elements that were a sort of link between the doctor problems and the nursing targets that could help explain some of the associations that we would be looking for perhaps in future studies. Okay. And so in conclusion, we saw that the documentation was a widely variable process between doctors and nurses, but also with the different cultures that we saw in internal medicine and geriatrics, that we, as we know, have different processes between doctors and nurses, but we really saw the differences in timelines and the priorities that were given to the different tasks. Of course, we have different terminologies, and what was interesting was how different teams picked out different relevant findings, even for the same patient cases. So we saw that shared core that could help us maybe in finding better associations between the doctor problems and the nursing targets, and the importance of how these associations will be changing over time as the patient evolves and gets better moving towards discharge. And actually what was really interesting was that doctors and nurses don't have a very good knowledge of how each person is conducting that documentation and reasoning process, even they work side by side all day in the wards. And so additional benefits that we saw, the participants were particularly positive about having spent the time together to learn about how each other thought, reasoned, and documented things, and maybe in finding how and where certain types of information could be found. And again, some of the junior residents were saying that since they had never considered reading nursing notes, maybe it's something that should be integrated in the training process for interprofessional educational programs. But that was an additional benefit. It wasn't something we were looking for. Next slide. And so here we're moving towards, once we confirmed that there was some potential in improving collaboration through the documentation process and learning more about each other, but also having different types of information hidden in quote unquote in different parts of the EHR, we were thinking about how to create clinical summaries. And to create summaries, I mean, language models are a great tool for doing that. But before being able to move forward with that, we had to think of how language models represent interprofessionality. So In this section, we were considering more that medical teams have shared overall goals. I mean, everyone wants the patients to be discharged to go back home, but there are intermediate goals that are professional specific or patient specific. For example, a doctor might focus, for again, taking pneumonia example, the doctor might focus more on weaning the oxygen and treating the IV antibiotics, whereas the nurse will be more focused on improving the patient's autonomy for daily activities so that they can be independent going home. The physiotherapist might be more focused on being able to walk up that flight of stairs that they need because they have a flight of stairs to walk up at home. And again, the patient might be more intent on being able to be with her dog again at the end of the hospital stay. And so this is where it starts being more interesting and working towards having a better knowledge of each other's competencies, but also of each other's goals. And this is the way that it could help improve interprofessional collaboration through anticipation of problems of each type of professional, and also a way to provide support for each other. So when we think about how to improve the team's shared mental model, here is a part about how important it is to have a better situational awareness of what each other is accomplishing. And one of the tools that we use in a shared mental model is to have the same structure for communication, which facilitates the communication process. And it's quite common, at least in our hospital, to be using this structure called the S-bar, which is structured with a situation, a background, an assessment, and a recommendation to summarize a situation or to do a handoff. And so what we proposed to do in this part of the project was to consider how this is only the doctor's view. There would be a similar view for the nurse on the other hand. So we decided to have two versions that we would propose. So on the left-hand side is the doctor's interface with we're still on our pneumonia case and diabetes with acute renal failure and chronic back pain. And on the right-hand side, you can see the two possibilities for nursing notes to be made visible for the doctor. So on the bottom side is the more basic side. These are the titles of the different nursing targets that might be used to monitor and help take care of a patient with these different diagnoses. And on the top, we were thinking that it might be pretty neat to have a summary of the nursing targets in text to have a better idea of what the nurses is managing. And this came up because when I was showing doctors the different labels for the nursing targets, it suddenly became a lot more difficult because it doesn't we don't use the same vocabulary. Hypothermia to talk about fever, an effective breathing pattern to talk about being short of breath. It's just not the same vocabulary and doesn't mean the same. And so since we don't have the same documentation processes and different reasoning and different terminologies, this is where we started moving towards Gen AI and trying to think about how language models can help us.
Okay, so hello everyone. So I'll take over now. So our first step was to select language models that we wanted to study, and for that we went to this just do that to this platform Hugging Face, where you can find hundreds of AI models free to download. So we ended up selecting 5 of them. So as you can see, they're all open weight model, reasonably recent, reasonably small. They're all, they're all multilingual model, as we obviously needed them to speak French, and they're all instruction tuned. Mistral and Mixtral are both developed by the French company Mistral AI. Llama 8B is one of the smallest models from Meta. Qwen is a Chinese model. It's the biggest that we included with 32 billion parameters. And the last one is actually a variant of DeepSeek R1 distilled into a Llama 8B, and it's the only reasoning model in our list. So we wanted to have an idea of how summaries would look for typical cases. So we first pre-selected all admissions in our Department of Medicine that had a primary diagnosis among the 15 most frequent. And from that initial pool, we randomly selected 40 to be included in the analysis. And so you can see additional filtering criteria here. But on the right side is an example of this NANDA structure that our nursing nodes all abide by. And as you can see, it's fairly complex. Each node has a domain and a target. And then they consist of one or more observations, which in turn contain one or more action, which in turn contain one or more outcomes. So naturally, we had to simplify this a little bit and flatten all these nodes to remove a bit of this complexity for our LLMs. So this is how we built our prompt. And as you can see, there's actually two versions of it. In both of them, we provided various pieces of information that we broke down into blocks. We gave the model a persona and a role. We explained the task. We also gave instruction regarding the look we'd like for the output. And we provided the target audience, so who the summary was intended for. We provided the flattened note and a few other things, like we wanted the answer to be in French, or we wanted it to be no more than 10 sentences in length. And the main difference between the direct and the iterative versions is that in the direct version, we simply glued all the notes together and asked the LLM to output a summary in one go. Whereas in the iterative mode, we wanted it to go through one note at a time and iteratively refine what we called a scratch pad. So this is what it looks like more mechanistically. So the direct mode here, all nodes are concatenated and fed to the LLM in a single inference call. But in the iterative mode, we enter this loop where each node is fed individually alongside this scratch pad that the LLM has to progressively refine and update until the last node for a given admission. And we did that because even though open weight language models have pretty large context windows nowadays, we might still, from time to time, run into a patient who has many, many nodes. And we also wanted to see how a tool could deal with these edge cases in real life. So these are the five target audiences that we wanted to compare. So we defined four explicit target audiences plus the use case where nothing was actually specified. So we had summaries for patients, for healthcare professionals in general, for nurses, and for physicians. And on the right side, you can see the pieces of text that we injected into the prompt. So, for example, for the patient, we asked for a simplified language without medical jargon, whereas for nurses, we asked more about the care processes, and for physicians, we were more focused on diagnosis or monitoring or the treatment. So this was a mixed method study, and that's the qualitative methods. So Dr. Blondon here thoroughly reviewed the summaries generated from 10 randomly selected admissions among the 40 that we included in total. And if you're counting with me, that's 10 admissions times 5 audiences times 5 models times 2 prompting modes. So it's a staggering 500 summaries. So she analyzed each of them along three main axes. First, quality, that is relevance of the elements that the LLM chose to include in the summary. She assessed suitability of the content and style given a particular audience. And she also looked at safety for clinical implementation, including the presence of hallucinations, of inaccuracies, and the overall potential harm that could be propagated to clinical practice. On the quantitative side, we looked for outcomes that we could use as proxies for summary adaptation to different audiences. So for the primary outcome, we used semantic similarity using a 768 dimensional embeddings generated by a French model named Camembert. We defined also three secondary outcomes that felt kind of complementary. So there was the readability score, an index of word overlap between different summaries, named the Jacquard index, and more simply, summary length. For all these outcomes, we ran the analysis separately for each model and mode. We adopted what we call a gated workflow where we started basically with an omnibus test to detect any significant difference among all audiences. And then if that test was significant, we ran post hoc tests for each pair of audiences with a home correction for multiple testing. And because the semantic score is actually a multivariate outcome, it's encoded as a 768 dimensional vector. And also because we had to account for repeated measures, we used a blocked Permanova approach on cosine distances between embedding vectors, with the blocks being at the admission levels. And if you're not too familiar with that, this is a non-parametric multivariate analysis of variance, which uses multiple permutation to model the distribution of the semantic of the outcome, basically. And then it tests whether these clusters in the semantic space are significantly distant from each other when they belong to different audiences. And because it's, after all, nothing but analysis of variance, we get an R squared, which tells us about the proportion of total variance explained by our grouping structure. So basically the effect of specifying an audience. And to calculate this distance between clusters, we used a cosine distance, as it's generally done with semantic studies, which is basically the angle between the embedding vectors. So in my two-dimensional example at the top, words that have a similar meaning will have a small cosine distance, whereas words that are unrelated or even opposite will have a larger cosine distance. And so that's just for those who may need a refresher about the embedding, the concept of embeddings. So to obtain these 768 dimensional embeddings, we used a pre-trained model named Camembert, which is nothing but an extension actually of the famous BERT model from Google, just with a little bit of French touch. And as you can see, if we train this model to predict missing words in a massive amount of text, it learns to place words that share similar meaning in the same region of space. And these multidimensional coordinates is what we call embeddings. And to make it just a little bit more concrete, I have here my lab, actually. And I've already loaded an embedding model. This is Word2Vec. This is not Camembert, but the same principle. And if you look here, we can print the embeddings for cats, and that's this big list of numbers. And we can do the same for the word dogs, and you can see that it points to the same region in space. But just in case you're not convinced, we can also calculate the distance between the two, and you can see that between cat and dog, the distance is fairly small. But if we do cat and spacecraft, which I believe is unrelated, the distance between becomes pretty large. And because we now have numbers to represent word meaning, that we can do some fun math with them. So we can take, for instance, the vector for father, the vector for woman, and add them together, but remove the vector for man. And of course, if we do that, we get mother. If we do scrubs plus lawyer minus surgeon, then we get windbreakers for some reasons, but like in the fourth position, we get prison jumpsuit. So this means it works. And we can do dogs plus meow minus cat, and this will of course give us woof woof. We can do bird plus meow minus cat, and it of course gives us chirp chirp. And I'm sure you can guess that if we do Santa plus meow minus cat, we will get ho ho ho. So that's a lot of fun. I'll just go back to the presentation. Um, and so just briefly, also, this is just to mention that in our secondary outcome, the readability and the token overlap scores that we use We did not invent these. They're actually more or less validated scores. The Flash reading score basically takes into account the length of sentences and the number of syllables in words, and outputs a number between 0 and 100, with 0 being hard to read and 100 being easy to read. And the Jacquard index basically looks at the proportion of words that are shared between two summaries. And it's in that sense sort of a less robust or less fancy measure of semantic similarity. So for the qualitative results, I'll hand it back to you, Catherine.
Yes, thank you. That was fun with your example. Thanks, Fred. So out of the 500 summaries that I reviewed, we got 13% that were not usable. A lot of these were from the DeepSeek Llama model. And basically, surprisingly, only 4% were production ready in terms of quality of summaries overall. The first thing that we saw in terms of quality was, despite the repeated instructions to provide output in French, 20% of the summaries were still in English, and there were numerous problems with the translations. For example, the term thrill, which we also use in French for cardiology, was translated to shiver, which completely changed the sense of the clinical documentation. Overall, the structure that we asked it to use with the S bar as a structure was well followed. And for the types of admissions, some of the information became rather vague, and they would say the patient was admitted for medical reasons, which provides absolutely no information. And we also saw that there were terms that were misinterpreted, or because of acronyms that it wasn't familiar with, it invented things. For example, RAD, which in French is a term to talk about discharge, was associated probably with radiology, and it was meant to mean chest x-ray in one of the summaries. And it invented acronyms like ATA, which means increased blood pressure, which we usually write as HTA in French, and it just invented the acronym of ATA, which was nonsensical for us. In terms of suitability for the target audiences, we saw that the summaries for the doctors, again, as we asked it to, were focused more on the diagnoses and tests, and for nurses more on the general patient care. And for patients, which was actually pretty reassuring, it was good quality generally in terms of vocabulary, and it tended to be more empathetic and actually reassuring for the patient. Although only 48 of the 100 summaries were addressed to the patient, so a little less than half of them. And there were some fun errors where at some point the LLM took the first person to say, "I am hypertensive, but do not feel sick." And that was one of the summaries that it provided us. In terms of safety, we saw that there were errors that could lead to difficulties on the clinical side, with errors in gender. The age, which wasn't given as part of the information, was, if it wasn't given, was sometimes estimated, and sometimes the reason of admission was wrong, and that was again 8%. We saw that there were other types of information that were not precise about the dates of admission, for example, or the location of the wound that was being treated. And there were differences in how it would provide dates and planning for the follow-up consultations. We saw that there were, and this was more worrisome, errors because the system could sometimes invent diagnoses as comorbidities like diabetes or prior heart infarction. And it also invented medications, and when this was about antibiotics and particularly anticoagulants, this started to become more of an issue. And finally, in terms of safety, another big concern was some of the summaries provided suggestions as the next step for workup, which were actually wrong. So that again was a big warning. And so the next slide presents the summary of all of our findings in these spider plots, where we can see that Quen and Llama were actually pretty good. Now, Fred, hit the first, please. So as I mentioned in the beginning, the DeepSeek Llama was the worst one in terms of usable output. And so we saw that it lost points there. And then in terms of quality, the Mixtral was actually pretty bad because a lot of it actually still came out in English, even if we asked it to provide it in French, for example. And then in terms of safety, the Mistral and the Mixtral were the two that were the most concerning in terms of invented diagnoses and wrong steps that were suggested. So that's a summary of those 500 summaries that we assessed.
And so for the quantitative results, for semantic distance first, so as you can see, we got significant results for a few models in the omnibus test, both in the direct and iterative modes. Perhaps a little bit surprisingly, DeepSeek, which was the most recent model, and perhaps the one we had the most expectation for, was non-significant. And this is perhaps because this is actually not the true DeepSeek, but a distilled version of it. Not surprisingly, Mistral was which was the weakest model, was non-significant. But what really drew our attention was that Quen and perhaps Llama, to a lesser extent, were really the model where specifying the audience had the most significant and largest effect. So if we look at Quen, it's quite interesting. In both prompting modes, we see a few comparisons that were highly significant. And looking a little bit more carefully, we see that these comparisons almost always involve the patient versus someone else. So patients versus healthcare professionals versus nurses or physicians. And in all of them, the audience explained about 10 to 15% of the semantic difference. Comparing between different subtype of professionals usually did not result in any significant difference. But perhaps another interesting finding was that patient versus no audience specified also resulted about 10% R squared, whereas no audience specified versus any professional was non-significant, which suggests that not telling the LLM anything about the target audience leads to summaries that are professional kind of by default. So if we look at Quen through a bar plot now, so this is inverted. It shows cosine similarity and not distance. But this is also quite obvious here. All comparisons involving patients are quite lower, so more different than any other comparison in both the direct and iterative prompting modes. For Llama, we see pretty much the same pattern, but perhaps a bit weaker. Patients significantly explained about 10% of the total variance in the iterative mode, but only 1% in the direct mode. And this is also quite visible in the bar plot. And for Mistral and Mixtral, we don't see this pattern anymore. And in fact, we do have a few significant results, but they're scattered about, and the effect sizes are much lower. Regarding the secondary outcomes, results mirrored quite well what we found for semantic similarity. For both Quen and Llama, we see that the summaries were highly, significantly at least more readable for patients than for other audiences, and that summaries for patient shared much fewer words with summaries for other audiences. And again, between specific subtypes of professional, we don't see any difference. And for the token count, there's little to say. We didn't see any specific pattern. There was a lot of variability. And I think in the retrospect, we have to recognize that this is rather a weak outcome that is not very informative. So this brings me to our conclusions. So we studied the capability of these rather small open weight language models to generate summaries tailored to different readerships, the patients, healthcare professionals, nurses, physicians, and non-specified. We found that the overall performance for these models remains quite limited. We had less than 5% of these summaries that we considered ready for clinicians. And this is probably explained by several factors. First, we have to acknowledge that the task was quite difficult. This is real world data with notes that are full of abbreviations, of typos, of linguistic shortcuts. And all of these are also very specific to the geographical region. This is also, of course, French, and although all the models that we selected were described as multilingual, we actually do not know the proportion of the data that was actually in French during their training. And importantly, we only provided the notes. There was only little temporal information and very little context, such as patient demographics or comorbidities, medications, or the overall hospital trajectory. Quen was definitely our all-time champion, both in the qualitative and the quantitative realms. And this was also perhaps expected as it's the largest model that we included with 32 billion parameters. It was mostly able to distinguish between, well, the patient audiences, but much less so in generating summaries tailored to specific subtypes of healthcare professionals. And this also was perhaps a bit expected too, because the concept of patient is semantically quite distant, and it's probably a much more granular task to differentiate a nurse from a physician than it is to differentiate a patient from any kind of healthcare professional. And last, when no audience was specified, summaries tended to cluster with professionals, suggesting that when no instruction is given, the models sort of default to generating outputs that look like the inputs. And so we have quite a road ahead of us. This study, I believe, guides us toward several improvements that includes better prompts, perhaps some supervised fine-tuning. We also want to explore newer models, and I'm thinking in particular of specialized models such as MedGemma from Google, and perhaps some smart agentic design where we could break the complexity of the task into simpler processes such as translating first, rephrasing, and perhaps validating. In the next study, what we plan to do is basically the same thing, but the other way around, using doctor's notes this time. And this is also probably interesting. These notes are usually better written and more comprehensive in our hospital, at least. And if this is all successful, we will have to tackle the question of implementing the tool within our EHR, which raises, of course, a whole bunch of new questions. But for now, I'd say we still have a few challenges to overcome. So thank you very much for your time and attention. And I think we are happy to answer any questions now or discuss idea or suggestion, should you have any. Thank you very much.
Thank you all for a really great talk. Oh, we see some hands, and there's also questions in the chat. Y'all can, I guess, start from whichever ones that you like to answer first.
Sorry. So, physicians in different departments may reason differently. How may that influence the communication and the use of language tools? So, from what I could see in the different ways people were thinking about the clinical reasoning, I agree that there might be nuances, but the general approach of a physician is actually still different from the general approach for nurses in terms of what we aim for in the diagnostic reasoning. We aim for different types of diagnoses. So I think it's interesting to consider that there might be differences, but that might be much further down the road because we have to deal with the bigger, obvious differences first, and then we can go to the smaller, granular differences. So I think that impact will be something that we can consider. Actually, we've kept to internal medicine and geriatrics intentionally because in terms of the reasoning process and the types of patients, they're actually much closer. So that's why we chose those types of patients to start with. Does that answer that question? Let's see. The second question was, oh, why mid-hospital stays weren't relevant. Oh, so maybe I should rephrase what I said about that. The differences that we saw between the admission and the mid-hospital stay were pretty small. And because it took them so much time to think about each of the different phases, we thought it was more profitable to ask them to think about the admission and the discharge, which were much more different than between admission and the mid-hospital stay. And in terms of communication and amount of data for the care plan, the biggest change is, of course, at admission, because that's when everything begins, and that's when there's a lot more monitoring to be conducted between the different assessments of doctors and nurses. And again, during the discharge, that's the transition phase, moving out of the hospital. So those are actually the two bigger phases of change, I would say, in collaboration and in planning.
Awesome, thank you. Uh, Jarvis, I saw you had a hand up. Did you have a question you wanted to ask? No? Okay. I actually had a question. Um, I was wondering, it's really cool to see like how many models you all tried, and then it's like you did different methods of the direct and the iterative prompting. I guess I also because we also tried using OHNLP. It's like also like a extraction tool. Um, but it's also, but more so, it's just extracting like specific concepts like time and then I guess diagnoses and things like that from like discharge notes. And then so I guess we also notice sometimes the model struggles a lot when the note is really long and it's like it misses a lot of the like not even just acronyms. It's like sometimes when things are written together, they might capture one, not the other. Um, I was wondering if you all noticed anything similar or would maybe like the length of the note kind of like impact the quality of the summaries you generate, um, or what do you feel was kind of like something these more general models struggle with the most?
Yeah, so we didn't see that. I would say we didn't really see that in this study, but I have been conducting other studies using these same models more or less.
Hmm.
And it's true that there is such a phenomenon known as the lost in the middle phenomenon. And because when we're constructing the prompt, and we ultimately will always want to add something more. And
Hmm.
at the end of the day, we end up with very, very long prompts.
Yeah.
And what I saw was that the more stuff we put in the prompt, sometimes it loses the questions or it doesn't remember, and that affects the quality of the response. It does. I think regarding the question of abbreviations and the lingo of the specific sub-language that is used, like in clinical text, I think if we ran other analysis with French and English in Montreal because we have both languages here,
Hmm.
and there's a massive difference between English and French.
Mm.
So I think these models they are really good at finding the meaning of abbreviations, even correcting typos and all that, but they're really good in English and not so much in French.
Mm.
Yeah.
That
And
makes sense.
of course, the size of the model is clearly a factor.
Yeah, that makes sense. Thank you.
If there are no more questions, maybe we can run through the last few slides. We had a few extra parts for the next step 3 and step 4, but we can also take questions if there are any questions left.
Um, I don't see any active questions right now. Please go ahead, and if additional
It's
questions pop up, we can.
sure. So this was just because it's our next steps and what we're moving towards. So maybe Frederic can move forward one. So the next part of this study was to think about how to do the implementation process. And this again, as Fred was saying, is a lot about at the end of the day, what do doctors and nurses want to see and what would actually help them in that collaboration? Is it showing the links, even if the links don't make much sense necessarily in terms of terminology? Um, the example I showed you, is it better to click on the title of a link that you're not sure what it means and to have that then the full text right behind and read it? Or is it better to have a short summary that might be too much of a summary to actually provide you with information and you still have to go click into it and see? So that's something that we'll be testing in a usability run study once we've generated the summaries for the doctor problems. We'll be creating mock-ups and running a usability test with a population of doctors and nurses to see which version they prefer. And then from then on, we'll be working towards how to implement that and to find the right place to put it into our EHR system. The final part of our study, which is the learning model, here's probably one of the bigger challenges, and I know that Fred raises his eyebrows at me every time I talk about this part because it seems so far away. It's because we saw in the study 1 that there was something that could be interesting to think about as links between what the doctor identifies as problems and what the nurses are monitoring or taking care of on their side through the nursing notes. We saw that through that center core of labs, vitals, and other types of documents and relevant findings, that there's something that helps create these links for that patient with the two sort of versions. One's the doctor version of the perspective of the patient, and the other's the nursing version. And what's actually interesting is our doctors' problem lists are coded with the ICD codes, and the nurses have their NANDA terminologies and their codes. And so it could actually be interesting to think about working with bigger data sets since those are international terminologies. What we saw in study 3 that will be helping us also will be that once we implement our system into the EHR, maybe we can look at what people are reading up on or what people are clicking on to see what's relevant and interesting for doctors and nurses as they read across the other professionals' notes, because that's something we're not as clear about. There's actually not much research on that currently. Next slide. And so just thinking about how to move forward with this part, of course, helping standardize a documentation process. If we could start and have models that could guide us through, okay, the patient's here for pneumonia and we have a list of problems and things that could help the doctor, and the similar associated nursing targets that could help us guide and help us implement maybe another way of documenting better within clinical itineraries, which are already quite well used. And as I was saying, since we're using international coding systems, maybe we could merge with other larger data sets and think of possibilities for collaboration to help work on this problem in particular. And of course, the challenges are pretty great, and this is what Fred always gets me on. So this is a big, huge project because I mean, patients have a lot of different problems and there are a lot of different nursing terminologies and notes. So how do we start small while aiming to ensure generalizability? How do we take into consideration the large variability that we saw in the documentation process, which is varied even within our own hospital, within 2 divisions? And I can't imagine internationally, I think from what I understand in other places, nursing may be more structured than what we have, or they still do a lot of free text in our documentation. And the final challenge is, it seems to me, and we've been looking around for other databases with nursing documentation data sets, which are a lot less studied than doctor documentation, which seems to be very widespread. So that's something we would be very interested in hearing your thoughts about this part, if there's any time left.
If I may just add, it's either a comment or a question. Just at the end, first of all, wonderful talk, and just to think about how some of these data sources may change or may not significantly change with ambient AI data capture that we anticipate will become widespread in terms of our data capture.
Mm-hmm. That is going to be a challenge, but that maybe could be helpful in helping the standardization process. So that might be a benefit for us to have clearer, better written easier to understand, and more standardization actually in the doctor side. Things seem to be always a little bit slower with what I see on the nursing research and nursing documentation, but maybe that could be helpful as well. I know that in our hospital, for example, 90% of people interested in using AI are on the doctor's side, and a lot less interest on the nursing side. I mean, maybe they don't have time, or they're not as visible. But as I look at our applied AI projects, they're mainly physician led projects.